by our partners. Of course, in this journey are the partners who bring together the countries, communities, funders, administrators, and healthcare providers. There are partners who bridge the gap from bench to bedside, from planning to performance. Today's researchers are provided with funding, accessibility to expertise, collaboration with global researchers, and accessibility to infrastructure as resources. They enable us to undertake competitive research problems, increase the research output, streamline its relevance, disseminate, and make it accessible to the public at large. In this webinar series, we will invite representatives from such organizations who enable and provide opportunity to do value-added research. Today is the second session of this series, and we have Dr. Swapna Uplekar from Foundation of Innovative Diagnostics, or FIND as we all know, with us. Welcome, Swapna, and thank you for being here. I would also like to welcome all other attendees who have logged in. Let me introduce to you the speaker here. Dr. Swapna is a senior scientist in the sequencing program at FIND. She's working on establishing the utility of NGS technologies for disease surveillance and clinical diagnostics. Her current focus is tuberculosis, COVID-19, AMR, and other pandemic-prone pathogens. Swapna is a PhD in the area of genomics and transcriptomics of TB pathogens from Swiss Federal Institute of Technology, Switzerland. Prior to joining FIND, Swapna spent 4 years at the New York University managing projects to build next-generation sequencing capacity in India for improved malaria diagnosis. On a personal note, Swapna is a wonderful person who takes keen interest in all the activities she is involved in. Without taking further time, I would hand over the forum to Swapna.
Great, thanks so much for the introduction, Aradhita. I'll just share my slides and get started. Can you see the screen?
Yes.
Okay.
Just before Swapna begins, just a note to the attendees, please type in your questions. We'll take those after the talk is over.
Yeah, I won't really be able to see the chat or
Yes.
the video.
We'll do that after you talk. Thank you.
Okay, so, well, thank you everyone for being here. It's a great privilege to be invited to be part of this webinar series. And as Aradhita mentioned, so I will be introducing you to FIND, the Global Alliance for Diagnostics, and also talking to you about specific activities that we are undertaking in the sequencing program at FIND. So as most of you may know, FIND is an international not-for-profit global health organization based in Geneva, Switzerland, but with regional offices across India, Kenya, South Africa, and Vietnam. Our mission is to ensure equitable access to reliable diagnosis around the world. We also have ongoing activities in more than 50 countries through our local and regional partnerships. FIND was established in 2003, initially as a product development partnership, or a PDP. PDP is essentially an organizational structure that enables public, private, academic, and philanthropic sectors to aggregate funding for development of various health tools, such as diagnostics, drugs, and vaccines, as public goods, basically. FIND was also appointed as the co-convener of the Access to COVID-19 Tools Accelerator, Diagnostic Pillar. I will say more on this later, and is a WHO collaborating center for laboratory strengthening and diagnostic technology evaluation as well. FIND is also a member of WHO's strategic advisory group of experts on in vitro diagnostics, known as CSIR-IGIB. And yeah, so essentially our current and past efforts, to make diagnostic testing an integral part of sustainable and resilient health systems has focused primarily on the disease areas that are listed here. So we've been working on TB, neglected tropical diseases, malaria, fever, hepatitis C and HIV, AMR and pandemic threats, COVID-19, of course, and also more recently on non-communicable diseases like diabetes. So my talk today is divided into two sections. In the first section, I'll give a general introduction to find and highlight key areas of our work and achievements. And in the second section, I'll talk specifically about the sequencing programs and our ongoing activities. So yeah, I don't need to preach to this audience, but I mean, we can all agree that diagnostics are central to quality healthcare. And yet 50% of the global population today has little or no access to essential diagnostics. In low and middle income countries in particular, the diagnostic capacity is limited only to 1% of primary care clinics and 14% of hospitals. Moreover, there are no existing tests for half of the top 20 diseases associated with most lives lost. The COVID-19 pandemic demonstrated a strong investment case for diagnostics. Reliable, affordable, and accessible testing can save not only lives, but can save money and empower countries to effectively detect and contain global health threats. FIND's leadership in the COVID-19 response, built on around 20 years of successfully driving innovation and delivery of diagnostics. So just to tell you a bit more about the organization, I've listed some key achievements here in the past several years, and I'll just go through them one by one. So first, in partnership with the Indian government, FIND expanded the molecular testing market with the approval of the TrueNat platform, which is the first point of care platform from an Indian manufacturer. And since its WHO endorsement in 2020, it has produced tests for over 14 global health priority diseases, including COVID-19 and tuberculosis. Second, FIND and the WHO coordinated an independent quality assurance program for malaria rapid diagnostic tests for a decade, resulting in 77% reduction in non-compliant or poor quality tests, with 90% of malaria RDTs sold globally now complying with the WHO criteria. Third, by making hepatitis C or HCV screening, confirmation and care available at primary care levels through introduction of RDTs, FIND demonstrated increase in linkage to care from less than 50% to over 99%. And this has led to HCV policy changes in multiple countries, including Malaysia, Myanmar, and India as well. Last but not least, in partnership with ministries of health from Kenya, Philippines, Lesotho, and India, FIND also worked on diagnostic network optimization tools, which generate savings in healthcare costs and also led to a significant increase in case notifications for TB in just a short period of 2 years. FIND completed its strategic period from 2015 to 2020 with several other achievements. This includes enabling 15 new diagnostic technologies, supporting 4 multi-disease platforms, supporting 19 WHO recommendations, developing 29 target product profiles. I'll talk more on what these are a bit later, training almost 10,000 health workers, and building capacity in over 3,500 labs across the world. Yeah, given that we are just getting out of the pandemic, I thought I would focus also a bit on the global pandemic response. And as you know, it was largely coordinated by the Access to COVID Tools Accelerator, or the ACT-A partnership. ACT-A was established in 2020 and brought together the WHO along with governments, scientists, industry, civil society, philanthropists, and of course, many, many global health organizations. ACT-A was organized into 4 pillars of work, namely diagnostics, vaccines, therapeutics, and health system strengthening. So each pillar involves collaboration through multiple stakeholders. And cross-cutting all of this work is the access and allocation work stream led by the WHO that is developing the principles and framework and mechanisms that are needed to ensure fair and equitable access and allocation of these tools that are being developed. Speaking of the diagnostic pillar, it's co-convened jointly by FIND and the Global Fund and involves around 30 international partners. Through the DX pillar, FIND has supported rapid development of antigen tests for COVID-19, secured access to almost 120 million tests for LMICs through volume guarantees, conducted independent performance evaluations for multiple diagnostic tests, and generated evidence for governments to make decisions on outbreak response strategies, including lockdowns and other interventions. The diagnostic pillar addresses the following key objectives that I've listed here. So there's R&D of tests and tools. There's initiatives for market readiness, supply, procurement, and distribution of tests, country preparedness, and last but not least, genomic surveillance. So FIND's new strategy starting in 2021 seeks to harness the momentum around testing for COVID-19 and capitalized on the game-changing technology advances that have happened during the pandemic. So these include, artificial intelligence, machine learning tools, mobile devices, other connectivity solutions, next generation technologies such as genomics and CRISPR, wearables, home use tools. And basically these have demonstrated that diagnostic testing is no longer only confined to clinics and hospitals. So I'll talk to you a little bit about FIND's new strategy before getting into our operational model. So this is, and of course, all of the information I'm presenting is available on the FIND website, and you can also download the strategy document. But in essentially, the new operating model at FIND harnesses the strengths of an alliance of partners, building on the ACT-A experience, and also building on the COVID-19 testing momentum. The 2021 strategy lays the groundwork to accelerate global efforts towards two main goals: universal health coverage and health emergency response. So in support of universal health coverage, our goal is to expand primary care testing to combat diseases that disproportionately affect vulnerable populations. For the second goal, to mitigate health emergencies, our goal is to strengthen diagnostic surveillance and response systems to contain outbreaks and improve pandemic preparedness aligned with a One Health approach. And alongside our efforts to serve diseases and populations, we are also working to strengthen health systems and transform the diagnostic ecosystem to maximize the impact from innovation to implementation. And central to all this is this alliance of key partners in the public and private sectors listed here. And our business model will create this cycle of technology innovation, which will enable supply of new and improved fit for purpose tools, and access innovation, which will ensure demand from countries in alignment with testing policies. So a little bit more detail on how this works. So in the area of technology innovation, we are working with countries to understand the diagnostic gaps and work on developing diagnostic tools to address these gaps. We also design and conduct independent evidence generation studies through a streamlined clinical evaluation program. And these data are then shared with key stakeholders like the WHO to inform global and national health policies. We also work with developers and manufacturers on innovative approaches to promote production of tests in low and middle income settings. And finally, we also develop market interventions to address issues such as affordability, supply chain issues, regulatory bottlenecks, to ensure that there is a clean path to procurement. So that was technology innovation. In the area of access innovation, we are working to design novel delivery models to increase uptake of testing beyond formal health services, such as self-testing and digital tools. We also support countries to embed testing and surveillance into their broader health strategies to promote integrated patient-centric testing. We're working to strengthen diagnostic capacity by providing technical assistance, developing implementation guidance and resources for training. And we also work with advocacy groups to develop accountability frameworks and country action plans to strengthen commitment to testing and ensure impact. So the detailed roadmaps and for some of the activities that are listed here are on our website. For the purpose of today's talk, I will only highlight a couple of resources that may be of relevance to all of you, given that the work at IGIB is primarily in the area of R&D. So what I wanted to highlight was first, the target product profiles that I mentioned for priority pathogens. So TPPs, or target product profiles, provide details on the minimum and optimal performance and operational characteristics of priority diagnostic tests. And researchers, developers, and manufacturers use TPPs to ensure that R&D activities are focused on relevant products and designed for the context and needs of the end users. And FIND plays an important role in coordinating the development of these consensus-based TPPs for diagnostic tools for a number of priority-related diseases. So this includes engagement and of stakeholders like researchers, developers, disease specialists, and end users to prioritize unmet diagnostic needs and to identify, discuss, and agree on the desired characteristics of priority tests. So here is an example from our website listing all the TPPs developed in the area of antimicrobial resistance. You will find similar lists for hepatitis C and HIV, malaria, TB, NCDs, and even digital health products. And if you can help meet, as a manufacturer, a developer, or a researcher, if you can help meet the TPP specifications for tests in our disease portfolio, you're invited to submit a solution for technology review. So that's the second part I wanted to talk a bit about, which is the technology scouting work at FIND. So we're always on the lookout for innovative, novel diagnostic solutions for the poverty-related diseases that we work on, because our goal is to support the journey from product development to market access and impact. So throughout the process, and in particular, we seek solutions that meet the specific priorities outlined in the TPPs that I just mentioned. And in terms of the support that FIND offers for such solutions, it's essentially advice on precise user requirements and expectations from public health authorities such as WHO, technical guidance on product development. We also have established partnerships with developers, manufacturers, and distribution networks, and can be a partner on grant applications as well. At FIND, we can provide access to well-characterized samples from our FIND specimen bank, as well as other developer tool sets, such as reference strains panels and assay reagents and so on. And we also support conceptualization and design of clinical trials and regulatory studies, as well as provide access to our network of clinical trial sites for partners. We provide advice on approval processes needed to get products into the public health markets in low and middle income countries in particular, as well as advice on the needs of the healthcare delivery systems in low resource settings. So on the website, you'll find information about the technology scouting process. There's a technology and partner selection guide available as well. And then there's a web form where you can submit information on any potential tools that are in development. I'll just end the introduction part for FIND by saying that FIND's unique position bridging the gap between public and private sectors allows us to bring a set of very diverse stakeholders to resolve technical, financial, and logistical barriers to diagnostic evaluation. And in addition to technology scouting, we also actively seek out partners. So on our website, you can see a list of currently open calls for partners. Yeah, I hope this has been a useful introduction to find for all of you, and I can answer any questions at the end. But this was basically it for the first section of the talk. I'll spend the rest of the time I have to give you an overview of the sequencing program at FIND and highlight the key areas of focus and our recent achievements. Let's just take a little pause here. So moving on, FIND's work in the area of sequencing focused on evaluating the use of NGS as an in vitro diagnostic solutions for drug-resistant TB. This started around 2017, 2018. Sequencing became an independent program at FIND in 2019 when we initiated the TB Seek and Treat project. I'll go into details about this project very shortly. We expanded to other disease areas shortly before the pandemic, but as with everything else, COVID-19 took over most of our work in 2020 and even 2021. But on a positive note, it also highlighted the critical role of NGS in infectious disease management. More recently, we have also initiated work on AMR and other diseases. And our overall mission is to promote scalable and sustainable use of NGS for diagnosis and surveillance. Our activities are across 3 work streams that are listed here. And the overarching aim is to build an ecosystem for broad genomics uptake and utilization in low and middle income countries. So I think most of you may be very familiar with NGS, so I'll not spend a lot of time going into details. But as you're aware, there is tremendous utility for NGS for infectious diseases. And I've listed some applications here, including treatment guidance, promoting diagnostics development, surveillance, outbreak tracing, and so on. Our team at FIND works to track and catalyze innovations in sequencing to make it suitable for implementation in low resource settings. So while we're primarily working on whole genome and targeted sequencing methods that have been well established for surveillance and diagnosis, we are also supporting R&D work for metagenomic and probe-based sequencing assays. For example, pan-pathogen or multi-disease platforms. Our projects typically focus on approaches to optimize sequencing workflows, to validate various models of delivery for sequencing services, to support capacity building, and also to more recently to leverage the existing investments in NGS that have happened during the pandemic. We also have partnerships with major sequencing manufacturers, and we work closely with them on specific projects. So, as I mentioned, we have 3 work streams characterized by the disease area of focus. I will go through each work stream, starting with tuberculosis, specifically drug-resistant TB. For DRTB, our expected outcomes are to generate evidence for use of targeted sequencing in DRTB diagnosis and to catalyze country adoption for diagnosis and surveillance of DRTB. That's quite a mouthful, but I'll explain to you all the activities that we're doing at the moment. So, as you may know, delays in diagnosis and treatment initiation of drug-resistant TB remain among the biggest hurdles to TB control and elimination. Drug susceptibility testing is crucial to determine the appropriate and effective treatment for a patient's TB infection. The WHO NTB strategy calls for universal access to comprehensive DST for all persons with any form of TB. Now, conventionally, TB DST has relied on phenotypic methods, which are based on observation of growth or inhibition of a bacterial culture in the presence of a drug. So these methods are comprehensive but highly time-consuming and have rigorous lab laboratory requirements. But there's an alternative because in Mycobacterium tuberculosis, drug resistance arises primarily from spontaneous mutations in the bacterial DNA. So this makes molecular or genotypic methods highly effective for detection of resistance. At the moment, there are roughly 15 drugs that are used for TB treatment, and the WHO guidelines recommend specific first and second line drug combinations as part of TB regimens. So most rapid molecular tests detect mutations in one or more gene targets and can predict resistance mainly to first line drugs, rifampicin and isoniazid, and some second line drugs like fluoroquinolones. So based on years and years of research, we know that detecting resistance to all existing and new drugs would require interrogation of hundreds of mutations in over 90 bacterial genes. For those of you who are familiar with sequencing, you can appreciate that NGS holds great potential as a result for TB, and it can provide DST that is as comprehensive as phenotypic testing within a much shorter time. Even today, whole genome sequencing works best with bacterial DNA from culture isolates. So targeted sequencing is much more appropriate for rapid DST as it works directly from TB patient samples and can allow detection of resistance to all first and second line drugs in a single assay within as little as 2 to 3 days. So I've also listed here all the advantages that targeted sequencing offers compared to the other existing methods. And it is clear that, establishing the use of TNGS for sequencing-based diagnosis of DRTB can drastically improve clinical outcomes. So in 2019, with this proposal, FIND was awarded a multi-year grant by Unitate. This project is titled Seek and Treat and is led by FIND and the WHO with the goal of establishing targeted sequencing as a diagnostic tool for DRTB. So we have designed the project to address key barriers that currently limit the utility of sequencing for patient care in low and middle income countries. In terms of the barriers from the technology side, there is no existing pipeline of standardized and validated TNGS products or workflows for DRTB diagnostics that are also cost-effective and suitable for utility in LMICs. So today, the project is made up of 4 outputs. The first outputs will generate the evidence and knowledge base on these targeted sequencing solutions required to support WHO policy. And outputs 3 and 4 will identify approaches to boost the adoption of commercial TNGS solutions in low and middle income countries for rapid TB DST. Well, go through each output one by one. Majority of our work since the initiation of Seek and Treat in 2019 has been on output 1. I think you can appreciate that one of the reasons for limited uptake of sequencing has been the perceived level of complexity that is associated with the workflows and the need to piece together disparate components that need to be validated individually by end users. So the broad components of any sequencing workflows include typically sample processing or DNA extraction, library preparation, sequencing, and then data analysis. So if packaged appropriately, these discrete elements can be transformed into a complete end-to-end solution. So we are interested in such solutions for DRTB diagnosis with optimal automation of sample processing and analysis and minimal requirements for specialized sequencing or bioinformatics expertise to run the workflow from sample to result. In 2019, we started the technology selection process for Seek and Treat using a combination of active tech scouting and an open call for expressions of interest. The technical criteria, for identifying suitable TNGS solutions was based on the target product profile that was published in the WHO and FIND technical guidance on the use of NGS for TB. So end-to-end TNGS solutions with the potential to meet the TPP criteria were selected for a phase 1 analytical validation that was carried out using a blinded reference panel. The goal here was to validate the dynamic range and accuracy of TNGS for detection of resistance to first and second line TB drugs. Based on the technical performance in phase 1, solutions were then selected for inclusion in a phase 2 clinical evaluation, which is currently ongoing in 3 countries, India, South Africa, and Georgia. The goal of phase 2 is to assess the diagnostic accuracy and operational characteristics to generate the clinical evidence that is required by WHO and its guidance development group for endorsement and policy on the use of TNGS solutions for DRTB diagnosis. So like everything else, our project was affected by the pandemic, and as per the current timeline, the clinical evaluation will run until the end of 2022, and we expect the WHO policy recommendations to be announced by early next year. The last 2 activities in this chart refer to output 3, which I'll go over in a bit. So that was output 1. Now, in order to be effective as an approach for drug-resistant TB surveillance and diagnosis, sequencing-based DST also requires a comprehensive knowledge base of the genetic determinants of phenotypic resistance. This is essential to accurately interpret sequencing data and to produce a drug resistance profile. Output 2 addresses this issue and involves the development of a clinical knowledge base at the WHO to manage global whole genome or targeted sequencing data and associated phenotypic data for MTB isolates. So the development of the data repository and knowledge base is still ongoing, but one of the first major achievements of this output has been the publication of the first global TB mutations catalog to predict drug resistance from genetic data. This catalog provides guidance to assess the clinical relevance of any detected mutation and harmonizes the interpretation of mutations identifying using sequencing or other molecular tests. The catalog was generated by joint efforts from FIND, WHO, the Cryptic Consortium, which is a large consortium that generated almost 100,000 samples with genomic and phenotypic data for TB, as well as other stakeholders that are involved in this work. And we worked together to compile high quality phenotypic DST and standardized sequencing data and established a validated and statistical approach to associate the variants with phenotypes. And based on the sensitivity, specificity, and the positive predictive value, each mutation has been assigned a confidence grading to indicate the strength of its association with drug resistance. So the catalog is expected to act as an international standard that national TB programs, researchers, clinicians, and industry partners can refer to, not only for diagnosis of DRTB and clinical decision making, but also to guide the development of novel diagnostic tests. The mutations catalog will be updated and revised, likely on an annual basis, to incorporate new data sets and information as it becomes available. And efforts to develop the second version of the catalog are already underway. So that's output 2. As it stands today, then, based on what I've told you, the existing guidance on use of sequencing for TB covers the technical guide I mentioned previously, which includes the target product profile, the recommendations on inclusion of sequencing for molecular DST as part of DRTB surveillance, and the recent catalog of mutations associated with TB drug resistance. In the last couple of years, we've also been working with the WHO to develop an implementation guide for incorporation of NGS in national DRTB surveillance systems. The focus of output 3 will be to develop implementation roadmaps and propose setting specific delivery models for use of NGS, not only for diagnosis, but also for surveillance in 3 Pathfinder countries: Brazil, China, and India. In the In the light of the pandemic and considering the scale up of NGS capacity in most LMICs for SARS-CoV-2 genomic surveillance, we have revised output 3 to also leverage the recent investments in sequencing instruments, sample transport networks, data management, and IT infrastructure. So in terms of the activities, what we have planned is to initiate baseline data collection on existing workflows and algorithms for DRTB surveillance and diagnosis, and then use these use this data to optimize the existing networks to incorporate the use of sequencing. Additionally, we will also assess optimal sequencing workflows, turnaround times, other operational characteristics, including capacity utilization, connectivity solutions for data reporting. And all of this will rely on the implementation guide that I mentioned to develop the roadmaps and costed operational plans that will be needed to implement these setting-specific delivery models. And given that once the NGS infrastructure is in place, it can be used for multiple applications, several aspects of this implementation guide are also equally relevant for surveillance of other pathogens. So I'll just spend a minute going over the key components of the guidance document that will be published in the next few months. So this is the title. It's called Practical Considerations for Implementation of NGS for DRTB Surveillance. And the first step to initiate the implementation process depends on the objectives set by the National Surveillance System. So this determines the intended use of NGS and also has implications on the choice of technology, equipment, site selection, sampling frameworks, and other key aspects of the DRTB surveillance protocol. The guide includes 6 key components that are listed here in this figure. And so they include country planning, setting up the infrastructure and sample referral networks, including equipment, supplies, regulatory processes, building capacity and setting up training, development and validation of standard operating procedures for lab workflows, as well as for data recording and reporting. And finally, methods to perform quality assurance, quality control, and a framework to monitor the impact of NGS introduction. And for each of these components, the guide provides practical supporting resources, including checklists and questionnaires and templates. The target audience for this document are basically all stakeholders involved in TB lab strengthening and program support. And the guide will be published in a couple of months and we really hope it will be widely used. So this takes me to the final output of the Seek and Treat project. Output 4 focuses on translating the evidence generated from other outputs, synthesizing them with additional analysis and research to then enable knowledge sharing and also guidance for key TB stakeholders, national TB programs, and implementers. Activities under this output will include cost effectiveness and impact modeling, generating market interventions and market intelligence to facilitate negotiations for access pricing. These will be done in partnership with the Global Fund and the Global Drug Facility to make sequencing solutions available in their procurement lists, engaging manufacturers to address key market challenges and improve access to NGS products. We will also do some qualitative and quantitative modeling, first on key success factors for sequencing uptake, based on the lessons learned through other outputs, and quantitative models to look at the global market projections and forecasting for NGS. And last but not the least, all of this knowledge needs to be shared with key stakeholders and advocates. So ultimately, we hope to address the key access barriers that I mentioned initially and catalyze a competitive market for sequencing technologies in low and middle income countries and expand its utility beyond TB also for other global priorities. I mean, COVID-19 has already set the path for this, but other priorities such as AMR, malaria, drug resistance, and other outbreak pathogens. I hope you're all still with me. I cannot see anyone. But let's move on to the second work stream now, which is dedicated to pandemic threats and COVID-19. And our goal here is to establish primarily the technical guidance and tools that are needed for NGS implementation and genomic surveillance capacity building. So the pandemic made it clear that genomics is a critical component of effective outbreak management. In addition to its role in identification and monitoring of variants of concern, it has also guided the development of diagnostics and vaccines and informed outbreak response strategies. Moreover, the sheer volume of genomic data that has been generated and shared for SARS-CoV-2 within the last 2 years is unprecedented. This has not happened for any other organism in history. There is also an increased awareness and interest now in building NGS capacity from donors and many global health stakeholders. And for the first time, the COVID-19 response mechanism from the Global Fund also provides funding support for countries to set up sequencing infrastructure. And as you may know, even before COVID-19, sequencing has proved valuable for research use in outbreak settings. In the past few years, sequencing has improved our understanding of the epidemiology of Ebola virus disease, Zika, as well as Lassa fever. And in order to support the implementation of NGS technologies and tools in low resource settings, we started by investigating the scientific landscape of pathogen sequencing as applied to outbreaks, and particularly to viral hemorrhagic fevers. So just before the pandemic, we published a landscape report identifying the most promising applications and existing workflows and protocols for outbreak pathogens. At the start of the pandemic, we conducted a similar investigation to understand how sequencing can be used to mitigate the pandemic. We also published an update to the landscape report in 2021 to outline the specific role of genomic surveillance in identifying and managing the impact of SARS-CoV-2 variants of concern. So all of these reports can be accessed from our website in the link that's mentioned in the link below. Since then, most of our work on COVID-19 has focused on addressing key gaps and needs to establish genomic surveillance in low and middle income countries. So we have been involved in training, developing tools and resources, as well as mapping and building sequencing capacity in LMICs. In 2021, the ACT-A Genomic Surveillance Working Group was established, and most of our ongoing activities I find were absorbed into the working group, given their relevance to the ACT-A priorities. So let's spend a moment trying to learn a bit more about this working group. It is co-led by WHO and the Rockefeller Foundation, and FIND is responsible for managing and coordinating all the activities. So this group has brought together over 20 global health stakeholders, including WHO, country representatives, global health organization, donors, and researchers. The main purpose of establishing this group was to position genomics within the diagnostic toolkit, as well as to coordinate investments and ongoing partner activities for capacity building in LMICs. Some of the key achievements of the group in the past year include mapping of NGS capacity and ongoing capacity building activities for genomic surveillance, developing technology selection and costing tools for NGS. This is still ongoing, and we hope these will be published soon. Engaging industry and identifying market interventions to improve access to sequencing products in LMICs. Promoting capacity building activities, I already mentioned that. And finally, developing also technical and operational guidance for NGS implementation. And more recently, we have created specific task forces within the working group to determine and support priorities and needs that are outlined in the global genomic surveillance strategy. So you may have seen this draft document published by the WHO. It highlights 5 key objectives of a global genomic surveillance strategy for pathogens with pandemic and outbreak potential. So these are improving access to tools, strengthening the workforce, enhancing data utility to inform public health action, maximizing connectivity for timely availability of data, and maintaining a readiness posture for emergencies. So in the remaining time, I will elaborate on two activities that we have carried out through the working group and at FIND. And these are mainly the NGS capacity mapping and partner activity mapping work. And I'll also share some details of FIND's ongoing work in countries to support the scale up of NGS for SARS-CoV-2 genomic surveillance. So let me start by explaining the rationale behind carrying out this NGS capacity mapping exercise. It became quite clear with the emergence of the variants of concern that there is a need to ramp up genomic surveillance globally. Now, the first goal of genomic surveillance is for monitoring known and emerging variants so that we can understand the effect of viral evolution on existing countermeasures. And the second goal is to guide countries in planning their real-time outbreak response and interventions using the genomic data in combination with epidemiological and surveillance data. So to achieve these goals, we wanted to start by addressing two key questions. One, how much genomic data, the first one was actually where do we need to start building and strengthening sequencing capacity in order to address the disparity in global coverage of currently available genomic data. Now, the GISAID repository holds a majority of the genomic data for SARS-CoV-2, and today there are around 8 million genome sequences available. However, more than 50% of these are associated only with 3 or 4 countries. So there is still a huge disparity and lack of representative data from low and middle income countries. Second question is, how much genomic data do we actually need to monitor known and emerging variants globally? So we have experts working on the answer to the second question to come up with targets and propose sampling frameworks for genomic surveillance. But the first question was a bit difficult to answer. However, we thought it was important to understand this capacity, particularly for global health agencies, donors, and implementers, because we expected that the capacity mapping exercise would help to prioritize activities and funding allocation in LMICs. It would support in planning and implementation of genomic surveillance. It would help to identify partnerships and coordinate investments between stakeholders. And last but not the least, this kind of mapping and a framework to carry it out would help monitor national and global progress over time. So we relied primarily on publicly available data for the capacity mapping work. So we started with these main data sets, 5 main data sets. The first 2 data sets are to map the diagnostic testing capacity. So we used information on testing volumes reported by countries through the FIND SARS-CoV-2 test tracker that's on our website. You can access it here, as well as testing policy data from the OVID or Our World in Data online resource. The next 2 data sets were used to understand the existing sequencing capacity and access to sequencing infrastructure. So for this, we used information on in-country NGS facilities published by the WHO, which includes reference labs at the national and regional levels. We also used information from networks like PAHO and Africa CDC to map labs in South America and Africa that are designated as regional hubs for genomic surveillance. And on top of it, we installed this information from 2 of the major NGS platforms. Finally, the last data set was just used to estimate how much sequencing is actually being carried out in countries. And for this, we just obtained the total amount of genomic data submitted to GISAID by each country, starting from January 2020. So we used these data sets to categorize capacity in these 3 key variables: diagnostic testing, sequencing infrastructure, and genomic data availability, basically. And we have used this data to create an online dashboard that you can access on the FIND website, as well as to propose a framework for classification of countries into 4 archetypes that rely on the methods that are proposed here. And the goal here is of these archetypes is basically to indicate the actions that are needed to address gaps in genomic surveillance. So let me explain. So at the lowest level here, we have countries with insufficient diagnostic or molecular testing capacity. So prior to any genomic surveillance or scaling up genomic surveillance, the focus here should be to establish sufficient testing capacity. At the second level are countries with reliable capacity for testing, but no existing capacity for sequencing. So for these countries, the near-term focus would be to connect to regional on setting up sample referral networks, basically to utilize regional capacity for sequencing, or depending in certain cases, basically building sequencing capacity from scratch, depending on country priorities and needs and the resources available. At a third level, we have countries that have existing NGS capacity, but it is not currently being deployed for COVID surveillance. For these countries, we would carry out a situational analysis to identify any challenges and come up with ways to leverage or repurpose existing NGS capacity for COVID genomic surveillance. At the fourth and final level, there would be countries that have already started to utilize sequencing, but there is a need to scale up, as well as to implement strategies to link the genomic data with epidemiological data in real time. So for these countries, the goal would be to strengthen their genomics capacity and also explore the possibility of establishing these as hubs to offer the sequencing capacity to neighboring regions. So these are the 4 high-level archetypes. And of course, there are numerous activities that need to be carried out across and within each category. And there are many more considerations, but what we propose here are just broad stepwise actions that will be needed to ensure that countries can go from having reliable diagnostic testing capacity to being able to operationalize the use of sequencing for genomic surveillance. Now, it's already been 6 to 8 months since we came up with this framework, and a lot has changed in that time. So what we have done is built an online dashboard to routinely update the source data sets and also refine the methodology to reflect the situation better in countries. The current version, so this is the current version of the dashboard. This is an initial map that represents the low and middle income countries. And we are continuously working to fill the gaps in the source data that we have and refine the methodology. But this is where the current version stands. In addition to the country classification, we also have provided access to the source data sets, specifically on diagnostic testing, NGS capacity, the GISAID submissions, as well as COVID-19 disease burden and case numbers. And you'll find these kind of interactive global maps on the dashboard that are searchable. So our main goal was essentially to understand capacity and needs in LMICs, but we are also now working to incorporate data from high-income countries, as we have identified certain high-income countries that are also lacking in the genomic surveillance capacity. So in addition to the capacity mapping, we also carried out a partner activity mapping exercise for stakeholders in the active working group. And this was to identify ongoing activities in LMICs for building or scaling up genomic surveillance capacity. So this is just an example for Zambia, and where available, we've also captured information on which of the 5 objectives from the global strategy for genomic surveillance are being supported in each setting. So we would like to utilize this information to identify potential partnerships and coordinate investments that will support the design of country-focused action plans, to operationalize or expand SARS-CoV-2 genomic surveillance. So this brings me close to the end of the presentation, and the last part was for me to just give you a brief overview of the various capacity building support activities that are currently ongoing at FIND. So, with the influx in funding for COVID-19 through ACT-A and other donors, FIND also started supporting countries in building capacity for genomic surveillance. At the moment, we have ongoing projects in 7 countries. These were only established in the last 6 months, and the number is growing. But the scope of each of these projects is basically to address specific needs and objectives of partners in these countries to scale up genomic surveillance for SARS-CoV-2. Most of the activities focus on just increasing the amount of data generated of genomic data generated for COVID-19. But we're also supporting some partners to develop surveillance strategies and establish sampling frameworks to address specific public health and research questions. So in addition to the capacity building work, we are also trying to obtain information from these partnerships that can be used to address other key priorities listed in the Genomic Surveillance Global Strategy. So at the moment, we're working to obtain data on existing NGS infrastructure, capacity utilization, and costing in LMICs. The goal here is to understand key drivers that contribute to variability in NGS costs across LMICs, since that is a huge challenge that we need to overcome. Thirdly, we are also trying to identify specific implementation challenges, and we would like to utilize this information to publish case studies, lessons learned, and success stories. And last but not least, using the country classification framework that we've proposed and our experience in building capacity in specific settings, we would like to develop standardized support packages and identify interventions to address the key challenges that limit the implementation of NGS. I think that is the end of the second section as well. That was it for COVID-19. So this brings me to the third and final work stream. So this part will be very short, as we have only initiated this work a few months ago. But for AMR, we have started laying the groundwork for using NGS, mainly whole genome sequencing, for AMR surveillance by mapping the existing landscape of tools and technologies that would be suitable for deployment in low and middle income countries. So our plan is to also develop a list of preferred product characteristics. So not an official target product profile, but similar, but a list of product characteristics for a sequencing-based AMR surveillance solution. And in line with the TB mutations catalog, we are also exploring approaches to collate publicly available phenotypic and genotypic data sets for select priority AMR pathogens to support the generation of an AMR mutations catalog. So all of this is really work in its early stages, but yeah, we hope we'll have something useful by the end of this year. Think so. Yeah, this brings me to the end of my presentation. I do hope it was useful and informative for all of you. Thank you very much for listening. Before closing, I would like to thank the sequencing team at FIND, which is led by Anita Suresh, as well as our donors and various partners in countries and in the public and private sector who have made all of this work possible. And thanks to all of you for listening, and I'm happy to take any questions if there is time. Otherwise, you can please feel free to reach out afterwards by email. And yeah, I think that's it from me. Thanks. I'll stop sharing my screen.
That was indeed a comprehensive, input of how FIND works and what is going on and that. So without taking any further time, there are a couple of questions that I can see in the chat box and the question box. So this is from Anurag Raj. He's asking, being as a computational biologist, how can an individual, beside partnership, contribute in development of NGS technology and workflows for FIND? You are muted.
Oh, sorry, yeah, I'm back. Um, so, I mean, yeah, I don't know if I understand the question really well, but
Maybe I can unmute Anurag and he
yes,
can
if he
ask.
wants to just ask, yeah, directly.
Wait, let me find it. Are you able to? Yeah, please unmute yourself, Anurag, and you can ask a question. We can't hear you. Maybe Swapna, you can answer from the question that's there. It's not able to
Yeah,
answer.
okay. And I mean, if I understand well, so I mean, I hope I've given you an idea of how Find works, right? So it's more than just the technology aspect of diagnostics. So there's also building capacity, implementation, thinking in terms of policy for a particular technology. So I mean, I am a computational biologist by training as well, but if you start thinking, you need to start thinking, I guess, beyond just your technical skills, and I think identify other areas of interest, and other key questions that are needed to establish sequencing technology for infectious diseases that you can support in addressing. I don't know if that answers your question, but if you have if you could be more specific, maybe I could give you more
So
information.
he's asking about how
Ah.
to directly get involved with Find
Ah.
as an individual instead of as an
Oh, like
organization
that.
and a partnership. How as an individual he can contribute in the development of these.
Yeah, so I mean, as you know, well, as an individual, so typically we do have consultants who work with us on specific projects, and this is just through calls on the website. And I mean, if you're interested in just learning how Find works, you can also, approach us to think of a short-term project or an internship. So, as you know, Find also has an office in Delhi, India. But I think it all depends on what kind of involvement you would like. Is it if it's more to utilize your skills or to learn about the work that Find does? Uh, Feel free to write to me separately, and then we can. I can see if I can be of help.
So moving on to the next question, there are a couple of them within the chat box. So Dr. Rajesh Pandey is asking, learning from the SARS-CoV-2 genomic surveillance, is Find planning for longitudinal genomic surveillance in MTB load region countries?
Yes, very much so. And so the Seek and Treat project that I described to you was initially the focus was going to be entirely on technology evaluations and trying to establish sequencing for diagnosis of drug resistant TB. However, with the pandemic, the pandemic really brought genomic surveillance to the forefront, and that has also led to increased interest in expanding the use of sequencing for TB surveillance. Now, drug resistant TB surveillance has utilized NGS for several years now, but still there are very few countries that have sequencing as a part of their routine surveillance systems. So, through the Seek and Treat project, what we envision is that the work that is done is going to, in the initial period, support genomic surveillance. And eventually, when there is policy available from WHO on the utility of these for clinical management of TB and actual diagnosis of DRTB, then we will start thinking of how to incorporate this technology into the diagnostic algorithms. So, yes, the idea is to activate existing sequencing laboratories or help build capacity in countries to start basically thinking of how to incorporate NGS in routine TB surveillance. And as you know, a lot of the data that we have for the mutations catalog actually comes from surveillance studies that are happening in countries.
I think you've partially touched on the second portion of his question also. Was also wondering whether wastewater surveillance is being considered important for MTB detection as well as MDR-IMR load for evaluation of mutations.
Yeah, for MTB, not at the moment. And even for, but I mean, for COVID, I know a lot of the current ongoing work is on establishing environmental and wastewater surveillance, since it has a lot of cost advantages also. But for TB, I mean, at least at Find, our initial focus is just to support, periodic surveys for drug-resistant TB using sequencing.
Thank you. And Dr. Savita Iyer would like to know about how Find enablers partnership building and funding, for example, response to a request for partners. And I can maybe unmute Dr. Savita, and you could, please unmute yourself. Yeah.
Thank you very much, Aradhita, and thank you so very much for the presentation this morning. It's been very, very useful. So I was just wondering if you could elaborate a little bit more, please, on how Find enables partnership building, because there's so many different actors involved. And for example, in response to this request for partners, that'd be very interesting to understand. Thank you.
I mean, so I'm not the best person to answer this question, since I mean, I as you know, so I've worked more on the disease program side, but the website has a very clear basically protocol or selection guide for partners, and explains the process that Find follows in detail. So I think I would just recommend you to have a look at the website, and then if there are still any unanswered questions, you can write to me, and I can put you in touch with the with the folks that actually are involved in evaluating these proposals.
Thank you so much.
Are you there?
Sorry?
Yeah, please go ahead. We couldn't hear you.
Hi, sorry, can you hear me?
Yeah.
Yeah, sorry, I wasn't sure if I finished answering the question. I'm not sure if I was audible.
I think that was fine. Thank you so much.
Okay. Yeah.
Thank you. I don't think there are any further questions. I can't see any. Thank you so much, Swapna, for your time and being here and letting us know about how Find works and all the opportunities and all the initiatives.
You're welcome. Sorry, I'm having some trouble with the connection.
That's okay. I think we come to an end of this webinar.
Yes, I think, we are
Thank you
good
so
on
much for
time.
being
Yeah.
here.
Thank
And
you.
I thank all the other participants also. See you again next month with another edition of this webinar. Thank you.
Thanks, everyone. Bye.
Bye.